Today we are talking about crisis response strategies for children, youth, and families, including children, youth, and families with intellectual and developmental disabilities. We have the wonderful Dr. Dempsey with us again here today to bring us all her knowledge, experience, and lead in this presentation. And again, today, we are focusing on mobile crisis services. Mobile crisis services provide rapid response, individual assessment, and community-based stabilization to Medi-Cal beneficiaries experiencing a behavioral health crisis. Through this benefit, we are aiming to transform crisis services here in the state of California by really focusing the response on being more resolution focused and providing relief to folks in the community. As always, mobile crisis services should be person-centered, trauma-informed, equity-driven, should really be a brief intervention, so focused on de-escalation and resolution, always working from a lens of least restrictive interventions, and being culturally responsive, linguistically appropriate, and accessible. And now I'm going to hand it over to Dr. Dempsey to do a quick introduction and take over.
Great. Thank you, Danielle, and welcome back. It's like from the participant list here, we're getting many folks who may have been here last time. So I'm recognizing some of your faces and some of your avatars and such. So welcome back. It's great to be back this week. We just saw you a couple days ago. And we're going to continue the conversation that we were having last week. And there will be additional information because, of course, we're talking about children and families. So there'll be that additional lens. And for those of you who maybe your first time here, I'll introduce myself again. I am a psychotherapist and a trainer and a counselor educator based in the Bay Area. So my background is mostly in community mental health. I've worked in community-based organizations and county mental health full-time for 20 years, including in clinics and treatment programs and schools and a number of different locations. And I also now have a training practice where I go out mainly with community mental health and county mental health and do trainings such as this. You may know me. A lot of people know me for motivational interviewing trainings or for suicide prevention intervention trainings or trauma-informed care trainings. And I have a private practice here in the Bay Area as well. So all these little different pieces that I do, and all of them are very important. And I'm always really pleased to come back and talk about anything that's really about how to best engage folks. So I'm very interested in the places that often are the most challenging, and just being really aware that the places that are most challenging, such as what you might encounter in crisis, is often a place where we can have such great impact and really instill a lot of important hope and tools. So I'm glad to be back. And just to let you know, as I talk and go through this training, there will be times when you'll recognize some material from earlier in the weeks. There's some things that we need to include, and it's not fundamentally different. So as you think about today, if there's things that we're going over, again, I'm going to really try to take it from a slightly different angle as far as youth and families, as opposed to just adult care. Feel free to add in, kind of engage maybe in a different way. If you're thinking, oh, I've already heard this, maybe there's other things that you can think about, or other types of questions that you might have as you're going through this material again. And feel free to always add into the chat box. Love to know what you're doing, your kind of experiences. We'll have places where we stop and check in, and like last time, just get some information from you and your ideas about certain cases, just because it's important to have conversations and start to apply some of the knowledge instead of just listening to me for 2.5 hours, because there's so much wisdom in this room, way more than I could ever possess. We have 162 and growing people here that are really able to bring in your unique perspective and experience, and we want to hear from you. And if you have not done so already, please do add your name, role, and organization into the chat. If there's anything that you would hope to learn today, I'm seeing there's a couple things showing up, like any tips for crisis in the moment. That's always important. You can see there's other things that people have. By all means, start to add that into the chat, and we'll keep track of those and make sure that I address things. So it's great seeing all your names, get a chance for you all to get reconnected with each other. So please feel free to keep adding your names, what you're doing, your questions, and your feedback. Okay, so here's here's our agenda. It's a tall agenda, but we're going to be able to do it. We're going to talk a little bit about identifying crisis. I will talk about trauma-informed crisis resolution and de-escalation. So it's one thing to identify crisis, but what's our approach, or really our stance, what we might call our therapeutic stance as we go into a challenging situation. We'll talk about crisis response for youth with IDD. So there's a lot of similar content to the adult piece I talked about earlier, but we will be definitely adding this youth frame, behavioral management and crisis setting. Again, more about the co-occurring conditions in IDD, cultural considerations for youth in crisis, and children in the child welfare system, another important piece, because that's often a place where we may see more crisis. Crisis safety planning and follow-up, and a little bit about California minor consent laws. Okay, and here are our objectives. Our objectives are, or should very closely be connected to this agenda here. We'll be looking at warning signs and areas of risk. Again, warning signs are things we want to explore, and risk factors might increase someone's vulnerability. Doesn't mean someone's going to be in crisis, but we know that they might increase vulnerability. We'll be looking at some of the general characteristics of young people with IDD. And we'll also be talking about other aspects of developmental disability or developmental issues like autism disorder co-occurrence. We'll be thinking about use of assessment strategies for early identification of mental health challenges and engagement into treatment, right? So there's always that piece of trying to figure out early on what's happening for someone. Of course, with younger people, it's a bit more of a challenge because they don't have potentially the linguistic abilities. They might have a little bit later on to tell us how they're experiencing the world. So talking a little bit about that. Talk about intervention strategies that will help families and caregivers as well, right? Because they're, of course, so much a part of a young person's world. How can we help empower them to have some interventions that can be helpful for crisis resolution? And really, we're trying to avoid hospitalizations and out of home care. We'll think about cultural considerations, which are always critical. It's important in terms of certainly showing respect and being effective in terms of our work. Thinking about best practices for engaging caregivers and natural supports. So know that a lot can come up around, I wish we had like lots of resources in our community. And sometimes, no matter what, we may not have exactly the resource that we need. And there's another way of looking at that, which is, what's actually already there kind of naturally in the community that might be really useful that we can start to engage. Think about care coordination. There's a lot of networking we can do with regional centers, schools, child welfare systems, medical systems, healthcare systems that can be useful. And again, we'll talk a bit about these minor consent laws. Okay, so again, this review of crisis and intellectual and developmental disability. So some of this, again, might seem familiar. So feel free to start, asking or thinking about questions, maybe even questions if you were here on Wednesday that you might have had since then or coming up as you hear this. And feel free to start to comment, ask questions. Love to hear it. So we always kind of start with this piece about, what is a crisis? And in terms of how we're thinking about this from a mobile crisis team, right? You can do a lot of different types of trainings and get different definitions for like, what is a crisis? And we're thinking here about our behavioral health crisis is any event or situation associated with an actual or potential disruption of stability or safety as a result of the behavioral health issues or conditions. And then the important piece here is the actual or potential. So sometimes there can be the situation where someone is really in it and really in an environmental situation that's incredibly distressing, a huge loss or something, something that's come up that's been incredibly disruptive, so often it's like around loss or trauma in many situations, or how, again, that's all subjective, how someone interprets that and responds to it. But it can also be, maybe a threat of, or it may not be actually happening, but someone's concerned about it or worried about it or anticipating it, maybe anticipating, a certain placement or anticipating having to, perform in a particular way, and that can activate the crisis. So it's always a helpful thing to know. We'll talk about this a lot, which is what's the context? What's the environment that's fueling the crisis? And this is also a really important piece. It's like, what are the brackets on a crisis? Often like they start when things start to fall apart. And for some people, for many people, there are like early warning signs, and that's a helpful thing for helping prevent future crisis. But often there's times when the crisis doesn't just pop up, that often there's things that have been breaking down for a while, before a crisis becomes really acute and really intense. And then, it may occur and be ongoing until there's enough stabilization, for someone to feel like they can, start to reconnect and re-engage and function, in their lives. So there's a lot of different pieces, which is why we spend a lot of time in these trainings, looking at all the different pieces that you might be involved in, or connecting or linking to. So in your team, of course, is that you are responding to Medi-Cal beneficiaries of all ages, and including children and youth experiencing behavioral health crises. And so what you're trying to do here with the your intervention, of course, is helping youth and their families, right? So it's always part of the whole family, and trying to help stabilize, prevent like out of home treatment. And sometimes that happens, right? We need to have out of home hospitalization or longer care placements, sometimes in treatment, or just residential for longer term. But we try to get in there early, and we know it's so important that us kind of coming to folks in a mobile response kind of situation is a way of being able to respond much earlier and probably much more effectively than what would otherwise happen, which would be many times a family waiting until things became really acute, or until something really starts to deteriorate. So we're trying to get there as soon as we can, and trying to also help not just stabilize a crisis, but do a lot of important linkage, like linkage to other services that can be helpful, and maybe starting to have some of the first conversations about what potentially could be a condition that for treatment, behavioral health condition, for instance, and just start that engagement. Because people have first contact with a mobile crisis team, people who are compassionate and responsive, that can make all the difference for a family, regarding whether or not they feel comfortable receiving services. So things that we can see if you have a young person's in crisis, and as I'm talking about this, and again, if you're here a couple days ago, and just in general, you might be thinking, well, these are things that are true not just for young people, but adults. This could also be true, and absolutely. So we just think that some of the ways some crisis might show up could be slightly different in terms of how it's verbalized or demonstrated. But in many ways, some of these warning signs are, can have some similarities, to be sure. Also, when we're talking about this, we talk about, especially like with intellectual and developmental disabilities, we're talking about how we respond to someone many times based on their developmental age, as opposed to like their chronological age. So a couple of days ago, I was talking about different things that we might do with someone who's an adult who maybe has a potential intellectual disability. And a way I may respond to a 28-year-old adult, let's say, might be similar to how I respond to a 12-year-old if that's where they're at developmentally. So it's having that flexibility to be able to understand how someone's in crisis, how they're experiencing it, how they're communicating about it, what they're needing, and to be able to respond appropriately. So that's an important piece. So just to be thinking about that. Warning signs of behavioral health crises. Sometimes it's like directly expressing suicidal thoughts, like I want to die, or I don't want to be here anymore. And if you've ever had a suicide intervention training, and you'll have it later, it's so important when we hear that to really absolutely always ask directly about, are you thinking of dying? Are you thinking of killing yourself? To be very direct about asking about those kinds of statements, because you don't want to beat around the bush with someone's expressing suicidal thoughts. Always want to pause and check that out. And then we also have like a letter B here, making threats to harm themselves or others. And sometimes that can be more vague, but we still, we inquire, we get curious about this, because we need to know, of course, if someone's, imminently at risk, someone, has a means or a way to hurt themselves or others, that needs to be assessed. Lots of young people do engage in self-injurious behavior, such as cutting or burning. So they're not necessarily stating they're going to hurt themselves or someone else, but it might be non-suicidal self-harm. Sometimes you've heard that term. That is not an uncommon situation to see among young people. So to be curious what they're asking about that, to be checking in with young people about that is totally appropriate. And sometimes they'll tell us, many times we notice, we might notice, cuts or burns on someone's arms, and then, there's always a way of being able to be, curious about that. Like, I'm noticing that and I'm wondering if kinds of responses that's caring and compassionate. We also have young people getting very agitated and aggressive. Of course, physical aggression, destruction of property, and makes a lot of sense if someone is really intensely distressed, and it could be a whole number of things. It could be around not getting what they want, but also could be like an agitated depression. Could be maybe even a really severe anxiety or huge loss, or experiencing or re-experiencing a trauma that result in someone behaviorally becoming really aggressive. So aggression can mean lots of things, especially among young people. So that's definitely something that we're of course attending to. If we have someone having hallucinations or delusions, and commonly like the medical term for that, psychosis, and sometimes if other terms for it include like engaging in non-consensus reality. This idea like folks are seeing or experiencing things that others around them are not, and that could be the indication of a beginning of a pretty significant like mental health challenge, like a thought disorder, let's say, or even a mood disorder. Or it could also be an aspect of someone's intense trauma often, or it could be also substance induced, which is not uncommon at all. Definitely something we want to check out, right? Because someone could certainly hurt themselves or others in that kind of situation. And if we have someone isolating themselves from friends and family, sometimes these things around isolation, it can happen and we may not notice it, right, at first. And families may not notice it, but that can be a really dangerous trend if there's someone just really, hiding out in a particular way where all of a sudden, like, what's happening? We don't know what's happening with this person, and they're experiencing a lot of distress or crisis or depression. And it's could be a really important place to assess. And so what do we do just in terms of our initial stance? So we got the sense of, okay, here's some things we're really concerned about. And generally, of course, it would happen in a prior slide is that someone might call us in for that. Right? You're not sure where to go necessarily until someone calls you, particularly. Could be a number of ways that you're called into a situation. And what's important in this slide here is we're thinking about like, what's our stance? Sometimes we call this like in the therapy world, like what's our therapeutic stance? Like, how do we show up? How do we arrive and come into the space? And so even if you're not a therapist per se, you are doing therapeutic work. You're a healthcare provider. And so one of the most important things we do is really think about, when I come into this, here are some things like I really need to do. Something to consider all along is that part of a mobile team's function, if you will, of course, is to de-escalate. But what you're doing in your stance and your presence a lot of times is helping to co-regulate someone, to help through your calm presence, kind of help them contain, help them maybe just calm down. Not like we're going to tell somebody calm down, right? Of course, you know that, but it's just being just our presence of like being able to maybe to slow down the pace, help somebody stop for a moment and breathe. And these other pieces here are also really important, like working with young people and their families. Because in any given situation, you might be in a room with just a young person. You might be in the room just with the family. The young person left, they ran off, and the family's calling you, and you roll up to the house, and that's all you have, is maybe a caregiver. So, or many times you may have the young person and the family, and you have to think about that as well. And it's like whether or not they should even be together sometimes, because if it's a family conflict, there might be times when just taking a break could be a really important piece. So what we're trying to do is we're trying to provide the youth and caregivers as much choice as possible during a crisis response. This is a very important piece of trauma-informed care, is choice. Because when any of us have experienced trauma, no one wants trauma. Trauma is not something anyone has chosen, right? And different situations can create trauma. And what's traumatizing is subjective. But one thing we do know, it's generally when people are experiencing something that causes them trauma, that causes harm, is that they don't feel like they have control in the situation. My usual coping mechanisms are not working. And I'm in a situation here where I don't feel like I have any choice. And then often the recovery is around how do I, work through, create a narrative around this trauma. So whenever we're able to give people choice, it's really protective against trauma. It doesn't mean somebody's happy in the situation, but it's empowering, and we want to help empower people because that's a protective piece against trauma. So we also ask who they like to have with them when we speak together. So for the young person, that's a really important piece. It's also helpful to ask parents like what has worked in the past. Young people and their families, they are the expert on themselves. Like they really do know better than anyone what's been helpful, and they've been observing this. And family members generally and caregivers, they know this person better than anyone else. They have often much love and connection to this person. Like they really care, and they've been observing this, and they are our best resources. And another thing that's really important, and a lot of this is from the motivational interviewing community, and many of my interventions today are from motivational interviewing, because what we're trying to do is we're trying to engage people in ways that help contain. And I am very big on reflective listening, which is that aspect of active listening, of being able to hear what someone says and mirror it back. Because here's an important thing, again, about being really trauma informed, is that nothing is more important at the moment when we first get to see somebody than just our loving and compassionate presence. Like that is medicine, right? That is the most important thing that someone needs right now, is to have someone else in the human race just really be there and say, this has to be so incredibly painful, just to be heard in whatever language, like literally whatever language that they need to hear it in. Sometimes it needs to be very simple language. Sometimes it needs to be a language other than English. I mean, we try to make sure that they hear that, but also that we just have this, this warm presence that feels comfortable to them, whether it means like, I sit close or I sit farther away, or whatever I need. I'm just, humbly trying to provide this, because at this point early on too, it's like, we want to avoid questioning, because, unless we have like an immediate urgent thing, like, there's a weapon in the room, that kind of stuff. Generally though, we want to have that more or less taken care of and resolved with the family before we go and talk with someone. We know the room is clear and safe. But the thing to think about here is that we don't necessarily want to go immediately into problem solving. Just stop and pause and listen for a minute, because there's no magic solution that's more important than our presence. And I spend a lot of time here because it is extremely important. It's an extremely important piece, and maybe will save you a lot of trouble just by knowing that, wait, I can just stop and breathe here for a minute. And hopefully it would also help with your own wellness. And again, I'm always big into, no matter who I'm seeing, if there's a caregiver there or a family member. I mean, I just, for adults maybe as well as for young people, just if they know them best, like how should I best approach this person? Like what is their language ability and verbal capacity? So this is not immediately knowable, but it's helpful to know if a 12-year-old you're speaking to has a 5-year-old vocabulary, right? Like, 'cause I can be making assumptions about their chronological age, but I have to think about their developmental age. Also need to know the nature of what activates the young person. And I'm big into like whatever object really helps comfort them, let's find it. Let's find it and make sure they have it. More about that a little bit later. So it's all about, the trauma informed is all about safety, and again, that reflective listening provides psychological safety, choice, predictability, trust, and involvement, helping the person become empowered. So another thing I really like to think about here, if we have this, calm, quiet space, and again, many times in crisis, there's a lot of chaos going on immediately. So if there is a calm, quiet place in the area to be able to help someone go into that space. And we know the folks that we work with, that their environments, are fairly chaotic, no fault of their own. Just the way some of our housing is arranged and the way people are forced to live, like it can be hard to find, quiet places, and that can be very helpful, even if it's, relatively quiet. Really important piece, especially with young folks, is to sit at their level and do not stand above them. Generally, like we're taller than a young person, maybe not. Again, lots of, taller tell our kids, right, but we try to, sit and be at like their level, so there isn't any standing above, because that can be really intimidating. Try to avoid power struggles and recognize power imbalances. Again, that's back to that choice and going slowly, because already walking into the room, I am much more empowered than this young person. Already a professional, already coming from a certain, maybe different culture where I have more power, potentially in the dominant culture. I may have more language, older, all kinds of things that are different from the young person, and they know that, right, clearly, and they're responding to that. So if we can have this thing, like, again, I want to give them as much choice as possible, and not force anything. Even if I was in a situation where potentially we did have to seek a higher level of care, right? And I'll talk a little bit about that later. Even if it's like, okay, we're going to the hospital now, or we're going to see your doctor now, and we're leaving the space and we're trying to help transport someone, I still try to give choice. Would you like to take this jacket or that jacket? Would you like your mom to come or your sister? Giving some aspects of choice is really important, even when they're in a situation where we can't give them everything they want. Avoid sudden movements, or sometimes even continuous eye contact. We have to be attuned to like what is helpful, again, to support co-regulation. Many people, when in crisis too, like direct eye contact is too much, and it's too intense. There can be a cultural piece as well. So we kind of assess that, right? We look at someone, if we could tell like are directly looking at them to getting them more, kind of tense, then maybe I kind of look away for a bit while I talk and just notice if that helps with the regulation. I also just try to breathe with them as well. I try to breathe slowly and regularly, and try to help, notice their breathing, and try to breathe together and gradually slow down my breathing, because that sometimes helps someone get in sync and regulate a bit. And again, is there anything we can do to immediately reduce their suffering? This is about compassion. And this is a powerful way to help someone regulate, but also to help engage someone. So again, a blanket, glass of water, what do they need? What would help their heart and body slow down? And I always put here, calling for law enforcement is the last resort. And that's really my piece is calling 911 is the last thing we want to do. And again, clearly there's a time and place for calling 911. And we're talking here about situations where we're not in immediate danger, right? So if we have situations where there's weapons out, there's things that people have known that this is not a safe situation, that needs to be secured first. But if, as a mobile crisis team, we're the first responders for non-immediate danger. Clearly the police are for, imminent harm. And so the focus of services should revolve around de-escalation, stabilization, and crisis resolution. And we want to avoid the unnecessary use of law enforcement and emergency out-of-home placements. So again, back to this place where we're not going to necessarily be able to, to resolve everyone's problems. We can't stop all hospitalizations, of course, being totally realistic about that. But there's a lot, and there's a reason there's mobile crisis response teams, and there's a lot of investment in it right now, because there's a lot of evidence, there's a lot of research around this is absolutely what to do. This is the way to really actively and effectively work in a community that's trauma informed, that's culturally responsive. Your work works. Basically, you're doing a good thing. You're part of a really important movement. A couple other things I'll say, and maybe I'll take a little stop and just see. But again, as we're de-escalating, I've already kind of said these pieces, but just to have this out here, so I wanted to make sure that everyone's really clear that no one's asking you to do something if you're not safe and they're not immediately safe. Again, it's the best we can to assess and create safety. And so again, that could be asking someone to remove any weapons or any potential weapons if there's any around, making sure that you're in a space where you could exit if you needed to, and there might be like a psychological safety situation too. For instance, maybe we have there's a conflict, totally common, or maybe there's a fight between caregivers or other family members or the people in the community and the person in crisis. Really engaging someone, or having maybe even the team, one person work on engaging the person who's not the child, kind of getting them into another space, having the child in one space. So there can be some psychological safety there. And again, that's why I'm also really into these slow listening, reflecting kind of responses, because it creates that sense of safety. So behaviors communication as well. And remember thinking of that, like whatever the young person is doing is trying to tell us something, especially for young children, because they don't necessarily have verbal capacity. So it may seem like in this situation that we're not having communication, but what they're doing is telling us a lot. And so if there is like more aggressive behavior, clearly that's telling us a lot of the distress that they're in. But it's also giving us a read, of course, of how safe they are, we are at the time. Let's see. All right. And another thing, in addition to like helping people, like choose everything that we do, like who will join them, what they want to bring to comfort them, where they want to sit, etc. Also, checking in on like pronouns. Younger kids, may or may not like connect to pronouns, but it's always important to ask. And again, I've had some people who don't really care much, but a lot of people do care, and it's meaningful to them that we ask. It's really important, and we want to go slowly and reassure folks that we're here to help. And this idea too of stepping away from the fixing it and trying to be calm, but not monotone, like trying to notice, pitch and tone of voice, so it doesn't feel like we're just really being flat, because we want to be calm and regulated, but we also want to be a bit animated enough so it doesn't feel like we're just kind of calling it in, so to speak, even though you may feel very alive. We just want to be alive and activated. We still want to be make sure that we're kind of doing some self-observation. See, how do I sound to this person right now? Okay, and in addition to the reflective listening, which I talked about a little bit as well, we also want to affirm strengths where possible. So doing so, like really reflecting on strengths, helps with recovery, and it helps someone see themselves as powerful and capable. Because at the time that someone is in crisis, right, they don't feel powerful and capable, right? They often feel just like really distressed and maybe like what's wrong with me? Am I going to be okay? Something going to happen to me? Again, folks are feeling really out of control. But if I can start noticing and strengths, it allows for a different level of engagement. I'll be probably speaking a little more about that later. But just this idea of, I'm noticing it takes a lot of courage to talk to me right now. I'm seeing that you're really scared and you're also willing to open up a bit, and that's really helpful. So being able to just be able to reflect on the things that someone's doing that shows whatever strength it is can be so important. Let's see. There's other aspects of a trauma-informed crisis resolution, de-escalation. Is certainly we want to be able to do some safety planning. So if we're in a situation, which we hope we're in, that someone is engaging with us, things are calming down. Once someone is calming down, we want to keep reassuring them that we're going to find a way of supporting them. So it's important to be able to kind of do a both and thing of like, I really get that this has been really distressing for you. And I'm really pleased that you're willing to talk to me about this, and we're going to work together on some plan to help you, not get out of this, or to have a life that is like less stressful right now. So it's both things, like this has been really hard and there's hope, right? We're kind of bringing both of those things together, because at a time when someone's really in a lot of distress, I don't feel a lot of hope, right? It can just feel like this is a hopeless situation, and that can really help continue to build the crisis. So if I can kind of be like, okay, we're going to get something started. Now, it's quite likely that in your mobile crisis position that you can get some aspect of safety planning going, that and you're not going to be able to do, maybe clearly not long-term safety planning, but you'll be able to maybe again get some basic wellness safety planning for now, while also linking back to care. And we're going to talk about that in a minute. I have a cool resource here called Navigating a Mental Health Crisis. It's from NAMI, the National Alliance for the Mentally Ill, and they have it both in English and Spanish. And it is a really great book. In fact, I think I used some some pieces for this, in addition to things I've done and, motivational interviewing that I'm very familiar with. I used a lot of the NAMI guide in this presentation, because NAMI does a lot of great work, really pulling together research and best practices and people's lived experience and putting it into, very, I think, very appealing and user-friendly resources for people that are free. So that link's nice. You can go to the NAMI site. You could potentially give people this link. I'm sure you might even be able to get hard copies. I'm not quite sure of that, but you could certainly probably print some out. And it's nice because it has things like that caregivers can use and do, and checklists, and it kind of walks folks through in very common language, which is really helpful. Okay. All right, so we have some questions. We'll stop here for some questions. I mean, I'm noticing there's some things in the chat. We're going to talk a little bit about consent later. Okay. So let's see. Psychological safe space prioritized for both youth and caregiver if enough responders are available on the team. That's asked as a question. Maybe there's a question about like what to do if there aren't enough care providers on the team. And sometimes, these are things you have to kind of really assess. Like, I think sometimes like the crisis level, the energy, the frenetic level in the household. Sometimes, I came from a really big family, and sometimes there's a lot of people in a space and a lot of folks coming around. And I don't know if you have capacity for additional teams to be called in, additional support, but that might be a helpful thing if I feel like I'm not sure about the safety situation here. If I need some more folks to come support me, that might be a potentially reasonable thing to do. Hopefully you have enough people on a team that you could get like maybe a couple of different rooms going of like a youth and caregivers, enough separation between at least those two parties, if that's what we're looking at. And okay, and then I'm noticing there's another question here about, do you have strategies around gaining minor consent for intervention with when and if the parents are not present? So we'll talk a little bit about consent. If a young person is over 12, right, they in an emergency situation, you feel like this is what's necessary. You can start having conversations. And I prefer to have like parents involved whenever possible. Talk about that a bit later. I'm noticing someone else has a comment here about contact parents or guardians by phone to gain consent and document it when it was given. Yeah, certainly we can think about all the different ways that we have to communicate with people if we're in a situation where we have a very young person and they're by themselves, which could happen potentially. I think typically, we're going to be mostly at people's homes or in schools, so there should be folks around. I mean, I guess we could, certainly anything's possible, right? That we walk in and there's like a 9-year-old by themselves in the house, which might in of itself be a whole other thing you got to be thinking about in terms of reporting. There might be other things going on there. In most cases, there'll be probably a caregiver around that can be assisting. And in schools, of course, you have school staff and school teams who can also be really helpful in this regard. Okay, so again, there's probably other things that you're in your wisdom that you're also already thinking about and kind of adding. So this is something I'm thinking about again, this idea of like reflective listening, and just a little practice of reflective listening. When I do motivational interviewing training, which I do a lot of, I have people practice reflective listening because it's so hard to do it in some ways. It's so hard to sit and listen and to reflect back instead of problem solve, right? Instead of ask a question, instead of, give advice, but just to be present with someone. So one of the things I do is I have people think of tip of the iceberg, right? Like when someone says something, there's like, that's just like the tip of the iceberg. There's that thing that they said, the words that they used, especially with young people, right? Because they don't have as much language capacity necessarily. That's just the tip of things. There's stuff underneath. There's meaning underneath. There's feeling underneath. So if a child says, "No one helps me. I can't stand having to hear how everyone hates me and wants me to change," what do they expect me to do about it? You hear that from a kid, maybe a child in crisis. You're sitting in their bedroom, and that's the tip of the iceberg, right? It's what we see on top. What do you think is under the iceberg? What is not being said? Go ahead and just like put some thoughts into the chat box And I'll give you some example. Okay, so Arturo is anxiety, anger, difficult expectations. And so kids is not very enthused to make the changes are being directed at them. Yeah, absolutely. Absolutely. So I'm gonna have to take a few more things. I'll show you what I do with this. What is being not being says I have no support. Mhm. So just to give you some ideas about how I might respond, okay, Athena says, I feel alone, there's something wrong with me, is I would use any of these kinds of thoughts that you're all coming up with to make a reflective response. So I'm hearing to say, like right now, you're feeling really alone and that there's something wrong with you and you don't have anybody who's really on your team. That might be my reflective response based exactly on all the great stuff that you're thinking is underneath that iceberg that person isn't saying. Yeah. Oh, I like this. Kevin, that's a great reflection. You're not feeling appreciated or seen. Kevin just busted out a reflection right there. Yeah. And I like Bailey's point here too. I might even say something like that. There's a lot of stuff going on right now, a lot of different things that you're feeling with all this, feeling not liked and people wanting you to change. And maybe sometimes you don't even have the feelings the words to talk about that. You're noticing I'm changing some of my language as I go along because I'm thinking about talking to a young person. So instead of saying express, uh, I say talk. Or I'm trying to think about like what kinds of language might they use. Yeah. So and there's so many great things in the chat box, but I'm just seeing some as they roll by here. It's really hard not feeling accepted. Just noticing what Leah put in the chat box. Yeah, you're feeling alone and in a corner. Can't do what you think they want. That's a beautiful reflection. So what you all are doing now is many of you are starting to do the reflections just by listening to what everybody else is saying and looking in the chat box. And that's exactly what we're doing that really helps people feel heard and that absolutely functions in a way that helps de-escalate. So you're helping to de-escalate. Really nice. Well, so I'm going to peek at a couple of things here. Okay. Feeling unwanted as a burden. Yeah, you may even feel you're feeling rejected right now by people. And so you might be noticing like that any of these responses, of course, is not going to solve the problem. And that's really not our role. Our role is just to help them get engaged, feel heard. And the ongoing care plan is going to be something that eventually, will lead them into a place where they can start working on this stuff, whether it probably will be some sort of counseling. Maybe it's some sort of like family intervention. Maybe it's, some other type of, medical intervention or assessment, even medical assessment. I don't know all the things that this person needs, but we'll start to build that out. But right now, your presence to regulate is like the most important piece. Great, thank you. This is great. And another thing I want to talk about then is again, as far as a whole discussion piece here, is I had mentioned the importance of like noticing strengths. And thinking about like working with someone, you're out there again, you're in the house talking with caregivers, talking with a young person. They aren't feeling particularly strong, and we know the problems, right? We're thinking about the problems. We're just talking about the risks and the warning signs, the things that we're concerned about. Absolutely, they're 100% there. So that's one thing. But what actually often helps someone kind of get to the next step, take care of themselves, get what they need, is our ability to actually notice their strengths, right? So when someone comes back and is noticing a strength of mine, I start to feel more empowered. When I feel more empowered, I feel more hope potentially, and my willingness maybe to engage in things like planning, treatment planning, care planning might really increase, in addition to de-escalating. So for the discussion here, I have a little different thing for us to look at. Noticing strengths, what kinds of affirming statements can you make to support someone? So example, it takes a lot of courage to ask for help. So you can think about this last example, but it might be easier to think about people you've worked with or imagining working with a young person. And just the fact that they're talking to you, like what kinds of things can you think of affirming? What kinds of strengths do the people that you serve tend to show up with? Willing to communicate, engage your own insight. You know yourself best. Absolutely. Yeah, just their willingness to communicate with us is an important piece. You're very strong and focused. Stand up for your needs. I like that, Megan. That's beautiful. Right. It was, someone told me that, and I was in crisis, and I was like a 10-year-old kid. Like, even if I didn't like fully, kind of understand or get that, just the kindness and that kind of response would be really meaningful to me. It can be really hard to trust professionals because we don't have a great job of trusting us and being open. Okay, so maybe I'm trying to think of the words of it's part of it, like your willingness to be open right now is certainly a strength, even though professionals aren't always easy people to trust. Yeah, I'm proud of you. Even adults have a hard time asking for help. Yeah, I think that's a kind of a reframing of that too, just having that different perspective. Like, this is not easy to do. You guys can talk about it. Yeah, willingness to be vulnerable and share space with me. Yeah, it's nice. Appreciate you sharing how you feel. It takes a lot of strength to do that. Thank you. Yeah, and if you come back, for motivational interviewing training, I go into a lot more detail about how to do some of these interventions as well. Not everyone can show up when they're feeling all these feelings. Yeah, it's nice. You showed up. That's great. And that's wonderful too, right? Because it's just your being here, just your willingness to talk to me is like such a powerful thing. So Adrian has a, you always get to do you has worked for me in some kids, small crisis stuff in schools. Kids have liked it when I use their language. Okay, that's a great idea. If you know certain like phrasing that they use to talk about themselves that they find empowering, that's really helpful. Yeah, great. Thank you for that. Again, so we're doing a little work here in terms of de-escalating, kind of helping to manage a crisis. All like really important next steps. And so we're going to move a little bit into the IDD again. Let me see, there's a couple of things that are coming to the chat box. Thank you for being open and sharing and allowing me to be part of your journey. Yeah, I think that's a nice thing too. When we just notice with them that they've chosen to, or they've been willing to, always like this willingness piece to allow us in a little bit. That's so important, again, especially for that power, because so many times, again, kids don't feel particularly empowered, just in general. And in crisis, we don't feel particularly empowered. So I like that. Thank you. These are great examples. So, so I am going to move into the crisis response strategies for children and youth with intellectual and developmental disability. And again, these are slides that you may have seen the other day, or mostly have seen, but thinking about it from, again, the perspective of young people and their caregivers. So again, the experience of crisis is subjective, and causes are external or internal. And so when someone's younger, they have just less experience in the world. So although it's true, like for any of us, I can get through something, and I'm particularly, it may have been distressing in some ways, but I don't go into crisis, but maybe I have enough coping skills to get through. Someone else goes through that, maybe they're really struggling with it and it becomes a crisis, and they don't have enough coping skills to be able to manage it. The situation itself may not be enough to determine whether or not someone's in crisis, although we certainly have some understanding of the types of things that people experience that are more traumatic than others, right? So if we have like a really difficult like situation in a school, a fight or a shooting, natural disaster, something going on in the neighborhood, any of that is going to really be distressing for the young people. Also, thinking about for children and youth in crisis, the cause is often developmental in nature, right? There's something that's happening that they haven't learned yet to cope with. But also thinking about these ideas of developmental pieces and the context, the environment, it's also really hard potentially for their caregivers. Maybe these are things that caregivers haven't been through as caregivers yet, or they may feel like things have really changed since I was a young person. I didn't have to experience like school shootings. How do I even manage this with my young person, right? Like that might be something that's absolutely understandably and real. So it's why we're supporting the young people and the family. And intellectual and developmental disabilities are often a significant part of presentation of crisis. So because the nature of intellectual and developmental disabilities makes it already challenging to potentially function in a community in general, that then when we go and throw in things that are distressing, or if we have situations where someone isn't able to get everything that they need, it just makes the floor higher in terms of crisis. It just makes us much more likely to actually experience that. So here's the thing we think about, that folks in crisis may have co-occurring needs that require additional considerations. So when someone's in crisis, like that's potentially, certainly as a behavioral health issue, but there could be like medical issues that are going on. There could be a co-occurring developmental issue that often has, communication and regulation and self-regulation and relational components as well. So what we're trying to do often in this situation is in addition to assessing and making sure things are safe enough to enter, we're also really trying to figure out ways that we can start to collaborate. Who do we have out there that can really help us? And that, we also want to know, and that's part of this training too, you'll get other information around this about what other resources are out there and can I plan ahead? Can I start to know like who might be in a certain situation, whether it's, a crisis line or a regional center or medical system, whatever it might be, that has some resources available for consultation when I'm out in the community and I have a fair amount of complexity. So it's so important that we have first responder teams like yourself who go out there and are doing this work. But we really can't do it alone a lot of times. And many times it's great to have some sort of backup and resources to be able to advise us, when we're out and just trying to figure out like all the needs of someone we're talking to. It's complex. So again, thinking back to what we're just talking about, always think about our services should always be person-centered and trauma-informed, and we talk about that a lot here. And so we also, think about this trauma-informedness in terms of someone with intellectual developmental disability from their deficits and needs within a system of care. We already know about that, and we also want to be able to kind of try to conjure up as well, what are the strengths and capabilities and ways that someone could potentially contribute to community. So this idea of person-centered care is we're trying to really think about collaborative supports with people with IDD that's focused on community presence, participation, positive relationship, respect, and competence. So knowing that although someone can appear to have like so many things like that they're struggling with, always trying to come into this with what are the things that balance this out in the individual, in their family, and in their community, because otherwise it's really easy to get very overwhelmed with like, this just seems too difficult. This just seems like so impossible. Like we can get really distressed that way. But then be able to think, wait, there's always a balance. People get by. People find ways of being able to get through systems, even though, we have a lot of situations where we don't have enough resources. We don't have enough access to resources. There's still ways of being able to thoughtfully and creatively connect people, even when it's challenging. So back to this idea that we talked about last time, an intellectual disability is when limitations in your mental abilities affect intelligence, learning, and everyday life skills. And as we said before, this can vary widely. And then, even among young people as well as among adults, some can be more kind of developmentally, quote unquote, on target for their chronological age than others. And, some people like, are needing like much more assistance even when they're quite young. One thing I think about with young people is often with IDD, not everybody gets all the assessment when they need it, and they don't always get it as quickly as they need it. So I think an important role for a crisis team kind of coming into a home is just knowing that with a young person, as opposed to, adults that we're talking about a couple of days ago, more often than not with a young person. This could also be true for adults. Like we may very well be at the beginning of their assessment journey. And there's things that we might be linking to that, of course, are important for the crisis stabilization, but it could be the beginning of like all of the assessment that this person needs. And for a number of reasons, people don't get the assessment that they need often. So we could be helping to initiate that. And there's a lot of reasons why that happens. There's just not a lot of access to some sort of care. Sometimes people just don't understand like developmentally what kinds of things their children need, right? Because can't always figure this out. Kids are different. Some kids may have some struggles, and it might be showing up more behaviorally than intellectual. So they're thinking, oh, just a behavioral issue. As you know, and any of you have had kids know, this can be really difficult to figure out. Just just because like what is problematic, what isn't. And again, some things are very clear, but some things aren't. So I think this is also an important thing to think about again is that intellectual disability is about 1 to 3% of children. Doesn't seem like that many, right? But it's actually prevalent. I mean, it's not it's not necessarily common, but it's evenly kind of distributed throughout communities. So you will definitely run into IDD out in your teams. And we call it in the DSM-5, now it's a text revision, TR, intellectual developmental disorder, intellectual disability. And if you have access to DSM, some of you do, clearly, and you use it as part of your work, it might be helpful just to really go through and looking at all the developmental categories, right? All the children, all the childhood issues would be helpful just to go and do a review now and again, because there's so much in there, so rich. It's always helpful to get a sense of like all the different things that start to show up, and it's easy to start to forget those. We don't always know what the causes of IDD are. There could be differences in terms of brain development. It could be brain damage, could be genetic issues that occur before age 18. So again, these are things that are diagnosed usually in childhood. Okay, so things that we're thinking about here again is how does IDD start to show up? And we're thinking about, okay, so some of it's intellectual, some of it's adaptive, and I'll say this a lot because it's such an important piece, but the behavior that we see is often because there's something that's been frustrated, and the individual may not have the words for it. We see this a lot with little kids anyway, right? They're trying to figure out how to manage their world, but we expect, as they get older and they get more independent and more language capacity, that ability to manage and problem solve and figure things out starts to increase. With someone with IDD, we may not see that in the same way, although we can have like uneven combined development, right? So we can have someone who might score higher on an IQ test, still struggle with some aspects of adaptive learning, and you can have someone who's adapting quite well, but they have a lower IQ. There's all different ways that some of this stuff shows up. So the intelligence related symptoms, and this is important too for how we communicate with folks, could be delayed or slow learning, slow reading speed, difficulties with reasoning and logic. And again, you'll notice the same slides really as with adults. Working with adults, which I do sometimes with IDD, I have to think about these things all the time, like cause and effect may not, those kinds of conversations may not immediately be apparent. Sometimes it requires like slowing things down, being really concrete, repeating things. Sometimes problem with judgment and critical thinking, problem solving skills and planning abilities, and distractibility and difficulty focusing can all be a part of that. So repetition, using proper languaging, sometimes using like non-written forms of communication is really important, like pictures, drawing, that type of thing can be very helpful. And again, all behaviors reflect some kind of communication. So an individual's limited ability to verbally communicate anxiety, mood issues, or psychotic disorder, again, that idea of like a thought disorder, a non-consensus reality kind of situation, it could show up in aggression or externalizing behaviors. And so we're always trying to think like, what does this communication, what are they trying to achieve? And again, knowing from the family member, if they know if they have a diagnosis of IDD, if we're suspecting that, it would be helpful to potentially create some sort of linkage for assessment. And usually, again, with the intelligence and the adaptation kind of pieces with the young person, if it's around IDD, it's when we're not seeing what we would expect for someone their age, right? So that's when we're starting to think, okay, maybe this is something where we need to start to do an assessment. So adaptive behaviors revolve around abilities and learn skills needed to live independently. So we have what's commonly considered the intelligence kind of indicators, and then the adaptive behaviors. So these are things that young people do, and adults that with IDD that potentially can be be difficult for them in terms of just getting along in our culture, being able to have, achieve activities of daily living, for instance. And again, this is something you might start to notice even with a young person, like slower learning of toilet training and self-care activities. So if you have like a 7-year-old who still isn't toilet trained, I mean, you can see like we have like things we gotta be thinking about here. It's like, wow, is this an adaptive issue related to IDD? Is there like a neglect issue? Like sometimes we have people who aren't taught how to do self-care and take care of themselves, right? So there's that might not be entirely something that you would fully assess, but certainly something you'd be thinking about, right? Like what's the environment around? Because we can see if there's like some significant neglect, some of these things could start to show up as well, right? Because these are things that we're taught. And if you get this sense of, wait, this, maybe there's a neglect piece here too, that might be a whole, another issue of, exploring. Slower social development, little or no fear or apprehension of new people, of the lack of stranger danger behaviors. So kids and adults should have a certain amount of like boundary, around new people. And so sometimes that lack of stranger danger and kind of running up to folks and such, is a real concern just for their own safety in terms of exploitation. Needing lots of help from caregivers to do daily activities. That goes way past their expected age. So again, if you go into a home and you're seeing caregivers, back to my example of helping a 7-year-old use the restroom, that kind of thing, like that might not be like something's going on here. Like query, like what's the developmental concerns, if they know of any, could be an important piece for assessment. Difficulty learning how to do chores or other common tasks, difficulty understanding concepts like time management or money. These are abstract things that we learn, take for granted in order to get along in the world. And that clearly can be an adaptive issue. Needing help managing healthcare appointments or medications. We don't expect like, young people to be able to manage that on their own. So that's probably a bit more for adults as well. And again, even with the money and time management, right? We think like what's developmentally appropriate for any kid that age. Trouble understanding social boundaries. And youth are starting to learn that, when they're in school. And again, thinking always about context. If I came in, I had like a 9-year-old that I'm talking to, and they're really struggling with social boundaries. It's like, okay, let me see, are there some of these other things in place? Are there potentially like intelligence things in place? Maybe I'm thinking of IDD, but maybe I'm also then finding out like maybe other things aren't entirely in place, but I find out they've never gone to school. Like we have like kids out there who have not gone to school because of COVID. And now, now they're continuing homeschooling, and there's different levels of homeschooling, right? In terms of like how much they get exposed to other people. Maybe that's why they don't know social boundaries. So it's like taking a lot of different things into consideration. Difficulty or limited understanding of social interactions, including romantic relationships. Right. So sometimes we can see that even with pretty young kids about, their expectation of like if they have a crush on someone, like they may be really violating someone's boundaries around that if they're totally into them, whereas someone else development may have known like you can't just go up and be like really aggressively into someone in the classroom, let's say. So these are all potentially things that we could see. Yeah, so there's thank you, Daniel, for adding the main diagnosis criteria for IDD in the chat there, and there's a question Adrian has, which is a great question. Like, if you notice something there about, because we're looking at adaptive and intellectual functioning. So if the main developmental delayed item 14 is lack of social boundaries, is this IDD, still have to meet the full diagnostic criteria, because someone could certainly have that adaptive issue. And there can be all kinds of contextual reasons why someone is really struggling with boundaries. Again, including some aspects of what are cultural norms for that young person, their history, the history of trauma, how they're raised, basically, some of that, like things that they were taught, things that they've been through. So, yeah, but that's good that you're thinking about this and thinking like, well, what other things but I need to consider if I was going to be considering this diagnosis. Okay. Thank you for that. All right, so a little more about management of behavioral crisis, a little more detail here about things to do. So we've been talking about, some aspects here of helping to regulate, kind of come into the room, our stance, kind of settling things down. So I'll put some other things that we're doing now to kind of move along in terms of um, behavioral health crisis. And so thinking of crisis as a symptom and not a disorder. So that is an important piece. And again, I'm kind of using IDD here as kind of an area of focus, although this is true for most everyone in a lot of ways, right? It's but this idea that crisis just is something here that's happening. It could be a piece of something much larger, or it could be something just like very contextual. So it's really important that we engage caregivers and natural supports as appropriate for background and collateral information. So caregivers will give us a sense of if there's been any assessment, what's it like, the depth of it. Really important, and we'll talk about this a lot, which is like the thing that may have been activating, especially for the young person. I know we talked about this before a couple days ago. Also thinking like, who do they have on their team? So natural supports could be, who do they have, like say at their school that they're really connected to? Is there, an occupational therapist that they see that they love, or, family member who's always around? Like those people could be really important. If they're available, maybe even it's great to have them on FaceTime or have them come by or whatever, might help with regulating and also giving us information. So again, when on set, we greet everyone involved. And again, this idea of voice and choice, like who would you like to have participate? And for youth that are nonverbal, which happens a lot, we use alternative communication strategies. I'm going to go through those again. And again, this idea of like, oh, it may not be a psychiatric problem. It could be something around physical health or just somehow their needs are not being met. This is not necessarily, an IDD situation, but, I'll say this as a little background story here. I remember it was probably getting to be about, I don't know, maybe 15 years ago or so, that I had a colleague who, maybe closer to 20, who was really, surprised and astounded that, they were working in a kind of hospital setting, and a young person was brought in crisis because their cell phone was taken away. Now it's not an uncommon thing, right? Like how addictive cell phones are and such. But we know like that's actually a really common piece in our life. But at the time, it just seemed completely preposterous. Like what is possibly going on that this could actually create crisis? But but that's the thing, right? Like you can think of something that's coming up, and maybe it's something that we're not aware of, or something that's new in the culture, like phones, and 20 years ago. That's all of a sudden creating just incredible distress. So again, this idea of crisis is they're not able to cope as they typically would. They're doing something elevated, something that's really distressed. So kind of think about, okay, what can we do? Not necessarily give everybody everything they want, but what can we do to kind of help with the coping piece and help to regulate? So as I talked about before about this idea of active listening and highlighting strengths that increases motivation. Also this idea of self-regulation too. Again, big part of what's going on in crisis is I've lost my coping skills. They're not gone, but I'm disconnected with them. I can't quite access them. So really helping to praise self-regulation, like noticing their self-regulation, noticing like the way that they're taking care of themselves, like the way you're hugging your stuffed animal right now, like the way you're taking deep breaths. Thank you for doing that with me. And then also just anything that helps them, sometimes with comfort or distraction, like, getting the safe object, getting a glass of water, having a snack, like that can do a lot. Any of you who've done like recovery work and substance use recovery might be familiar with the idea of hungry, angry, lonely, tired. And we talk about HALT because it's often something that can activate someone's recurrence of a substance use condition, right? Because I got hungry or hangry, or was by myself, or tired. And I think that's true for anyone. And I think that could certainly be a case also for a young person that maybe they have gone a long time without eating. They weren't being they didn't get sleep for some particular reason, didn't get their nap, and any of that could really trigger someone to go into a crisis. And maybe if there's a developmental disorder also occurring, that can just increase vulnerability. I love the idea of modeling here too. So modeling is when we're intentionally showing another person what's ideal behavior that can help the young person understand like what we are looking for, right? So our presence and our calm presence in a crisis situation is an aspect of modeling for sure. So one thing we're doing here is we want to help to like bring caregivers into the scene, and sometimes I also encourage people to have like separate spaces to talk with caregivers about what's going on for someone, the symptoms, current stressors, and what do they think is causing the issue. And you all know sometimes we have caregivers who they have an idea of like what's causing the issue, and they may feel very passionate about something, and they may be right, they may not be right. We don't always know that, but sometimes the way caregivers are communicating can be part of the price crisis. This idea of, they got upset because their iPad broke. They're just a spoiled brat, or they're talking that way, they should know better, and like loudly talking about that. That in of itself could be a really important piece, right? Of just being able to like help regulate that caregiver, because we have a co-dysregulation crisis going on here. So you've probably seen that a fair amount. But I know I certainly have. Again, this idea of avoid being over directive with the caregiver as well as with the young person, because that often escalates crisis. And also it accentuates difference as well. So if there's some tension potentially around difference in power, that is really accentuated by being over directive. And so if we can kind of suss out like what are some contributing factors, we can start to approach them as best we can, and thinking about what is best to be approached first. So for instance, with a broken iPad kind of situation, it's not like we're going to run off and go out and immediately buy an iPad, but we can certainly be having calming things down and having conversations about what's it like in different ways, and maybe resolving the loss of that particular object. Whereas if someone's having like a medical crisis, right, I'm going to want to attend to that like immediately, seeing getting hold of doctors, potentially getting someone into an urgent care appointment, really sequentially, and really triaging what needs to be attended to first. Again, we talked about this nonverbal issue, and this is really important with young people. So I know I talked about it with adults a couple days ago, but we have young people who, again, they're just learning how to speak. If someone has a developmental disorder, it may be even more challenging. They may not have as many words yet. They may not feel as comfortable with language. We also have, I always have people talking to me about their selective mutism, which I guess is a thing, where someone can speak, they just won't. And I always think about that. If someone can speak and they won't, that's how they're finding their power, in most cases, right? And so if I just try to be, calm and curious, and giving them options, they don't always necessarily start speaking, at least not immediately, but they'll be often open to communicating. And sometimes, again, this is more long-term stuff, over the course of time, often they'll start to communicate. But the things we try to do here is we just try to include them. So even if they're not speaking, it doesn't mean they can't hear us. Because I know it's an easy one to get caught up in, like, oh yeah, they're not talking, but it's not like they're not here. And fair enough. I think it's easy enough to get caught into that way of thinking. And then also, because they won't talk, doesn't mean like they're like an infant, right? So being able to talk to them like as the age appropriate, to the extent that we know that they can, that's where they're at developmentally. Again, this is where it helps to check in with caregivers about, is this usual? How do you usually communicate with them if they're not talking with you? And try to get some ideas. Reduce distractions is really helpful. Another important thing, I think, is there's different ways the kids can communicate. Like whiteboards are really helpful. So some people have different communication boards. Sometimes people even have like communication boards set up for young people to write on. Music and reading. Sometimes if someone is not willing to talk, sometimes they're willing to play a song, or read from a favorite story that's describing how they feel. But it's a way of getting started, to assess what's going on for someone. Using pictures, objects, or writing. Had a student of mine, we weren't talking about this in particular, he was just talking about a situation that he was dealing with this week, and makes a lot of sense. I don't have it on here, but clearly like laptops and iPads are very, very helpful. And a lot of young people are very connected to iPads, laptops, and phones. Any of those things that often, if someone has, like, they'll often communicate with. So we're trying to just figure out the way that they're comfortable with this. closed-ended questions can sometimes be helpful just for basic information of just like, are you planning on hurting yourself right now? If you are, like, they may not tell us how they are planning on doing it. So again, if there's any indication of suicidality, that's where we ask the closed-ended question, are you planning on killing yourself? I mean, we're just, to the best we can, if we're at that place, we want to be able to ask those questions. But there could be other open-ended questions, or closed questions rather, that give us enough information to start to, have some sort of sense of how they're doing. Are you comfortable right now? Where would you like to move? Maybe they'll say one or two words or point, that kind of thing. Or we're trying to just stay as connected and patient as possible. So our nonverbals are important as we're co-regulating everyone in the room. I can't really bring that up in this a lot. And I'm just noticing, Arturo, your comment, like, they may not be ready yet. Patience and persistence, absolutely. It's really a thing. And here's another thing I think about. And Arturo, your comments making me think of this, is I think sometimes we get this sense of, I'm just here and they're not doing anything. I gotta get this managed, and if someone's like just sitting with you and they're not escalating, but they're there, they're present. Maybe caregivers are getting regulated to a certain degree, like that's all work, that's all getting the job done. So I think that the being patient part is actually what needs to happen. Like, that is crisis management, right? Is being present, being patient. So the co-regulation that we do, and again, this is all good work, good crisis management work, is making sure we breathe slow and regular, maintaining eye contact, speaking slowly and calmly, model containment through slow speech and pauses. I think we're all like this, but I can know for myself, more anxious I get, the faster I talk. And sometimes I talk really fast anyway. I'm probably talking faster right now because of time constraints. But the slow speech and pauses I often find really helpful too, just for like cultural responsiveness. A lot of times, I'm from many aspects of culture, of the dominant culture, and I know, like, we tend to talk really fast, and that's not the way most people in the world talk. And it's like, just be able to just talk more slowly and to be contemplative, pause. It's just really respectful. I mean, it's a respectful way of being able just to honor a different process, right? And nothing's worse than, I think, if someone's in a crisis and there's some sort of sense of hurriedness. And in the most recent version of motivational interviewing, I think there's something to the extent of, it's counterintuitive. I think sometimes it's like, the more we slow down, actually, the more it helps engage people and actually moves along a process. And the more we feel pressure to hurry something up, the more it kind of upsets people in some ways, and it slows down like the exploration. So it's counterintuitive, but it's almost like go slow to move faster in some ways, right? And also, we can reflect on nonverbal behavior too. I talked a lot about reflections. If someone's not talking to us, we can still, reflect on what we're seeing. Does it seem as you're happy to be here right now? I see that you're angry and maybe not too happy about talking with me right now. You seem upset and hurt. And, that's a part of doing that important reflective listening, even if someone's not verbal yet. Okay, we got a discussion piece here. Okay. Again, this is a time for you just to be able to show your stuff, and the intention here is, just see what kinds of things you're thinking about, and we can answer. You don't have to answer all 4 of these questions. You can pick, some aspect of this. But here's a situation. You receive a request for response from a parent who's concerned their daughter, Jessica, is appearing to regress after making some progress with toilet training and is becoming agitated and aggressive. So kicking, screaming, hitting, and throwing things, making threats towards them when they're instructed to use the restroom. When Jessica is instructed to use the restroom. Jessica is currently threatening to harm her parents if they make her go to the restroom. Jessica is 6 years old and is attending a special needs kindergarten. Jessica speaks very little at school, but speaks more at home. She's friendly and eager to make new friends at school. The parents also reported that the day before she started to refuse to use the toilet, she came home from school upset, but unwilling or unable to say what happened. The parents are concerned about potential abuse at school, as Jessica's social ability can result in fewer boundaries with adults and children. So they're afraid that maybe somebody's hurting her, and that's why she came home upset. So that's all we know, right? I made it, intentionally vague. So you have to think like, oh, okay, what kinds of things do I want to know? Because that's the way we show up sometimes on the scene. We don't have a lot of information. So given these concerns, how might you approach interacting and engaging with Jessica and her parents? What additional information would you want, or what questions would you ask? And what strategies would you use to support de-escalation? And what are some strategies to support communication with Jessica? And again, I don't expect that every single one of you are going to answer all four of these questions, but if you see a question here that like really resonating, just go ahead and put a few things in the chat just to give us a bit of a break and a chance to discuss some of this. What are some of Jessica's preferred activities and soothing items just to help Jessica at that moment kind of regulate and be able to bring in the room? Yeah, absolutely, Carrie. Thank you. Giving Jessica some choice. She would like to talk with or without parents present. And with the 6-year-old with IDD, I know that the parents are going to be more involved in any case, right? Because of the chronological age in addition to the developmental age. So they're definitely going to be around, but there might be a chance of being able to, that's an important choice piece, give her some private time. And so around number 4, what are some fun things she likes to do at school or after? Okay. Yeah, so Carrie's thinking about what's the support team the family works with. They could be really important to contact with right now, because there could be a person they trust. Often with support teams, they may have more of an inside knowledge too of what's going on for Jessica at school. Exactly. And all these things, it's like, yeah, these are just some real basic things to get started. And already you're probably starting to really de-escalate the situation. Be sure Jessica, it's her choice to talk with the crisis worker. Nobody's going to make her do or say anything she doesn't want. Yeah. Maybe start to game or to engage so she feels more comfortable. Makes a lot of sense. Eco has a strategy of usually engage with the child first, answer parents' questions second. Yes, I'm sure it might depend on the situation too, like how you might approach that. But it's great to kind of come in with your own strategy that you're thinking about in terms of how you like to approach this. Yeah, so Maria's also looking at what there've been any major changes and when did she start school, and that sometimes there are things that are going on. Doesn't have to be anything sinister, but there could be something that's happening that's activating this. It does seem like there's something that's activating this at school. So it does seem like, okay, something happened, right? It could have been a fight with a peer. Parents are worried about abuse, but it doesn't mean it's happened. So we want to be able to check these things out. Yeah, so Julie checking with the parents. What's the history? Y'all come up with great stuff here. Yes, definitely want to be at her same level. Oh, that's neat. I like that idea of having your own toys with you. You want to come play with my toys? Great idea. Come with the fruits and snacks and coloring books, things that we know engage. Yeah. Yeah, so many of you are thinking about like the school situation, like what are some changes, what kinds of things have activated that? Absolutely. Because all of this will be important, right? Because we're going to probably start using some aspect of the natural supports, the schools, something there to help either address what's causing the discomfort at school, or to really assess if there's something that is really problematic or abusive. I'd be interested too with the parents about like in being my curious conversation with them about why are they concerned about abuse, like try to get a little more of their story there. Yeah, trying to present a smaller and friendlier, okay, something safe and easy to engage. And Kara has a really important part here too about how there have been other changes in other areas. So it could just be school, but maybe there's something with a more global that's happening for Jessica. I'll be able to assess. Great, thank you for that. And there might be other things that we're thinking about here, but for interest of time, I'm going to just move along. If you have some other questions, we will have a chance to talk about them when I finish up here in a minute. So I talked about this a little bit earlier in the week, that there's other developmental issues that potentially come up and often are co-occurring, really often are co-occurring. Substance use disorders might increase impulse control disorders. And increasingly, we're thinking of SUD as a developmental disorder. There's There are debates about that. I tend to see it as more of a developmental disorder. For the younger kids, probably not so much of an issue, but we cannot rule that out. People start experimenting with substances pretty young. So for some people, it's as young as age 10 or 11. It could be even younger, but something we always want to kind of think about in terms of like peer groups, even parents. Like, not that parents are necessarily getting their kids high, but it's not uncommon for kids to get in their parents' stash, especially when people, cannabis is really easy to have access to. Edibles themselves are appealing. Um, you know, kids may just think they're candy, right? There's those types of things we're thinking about, not like the child has a full-blown sud, but that there's that piece there. ADHD is often a co-occurring piece. And again, we talked about like distractibility and focus being part of the intellectual piece. So that can also show up, of course, if someone has ADHD. You have the two together, then you may really have to work on helping to engage around focus. Um, uh, Autism spectrum disorder. So there can be issues there again around the verbal abilities, and also just around flexibility. So being very, careful about things that could activate someone and cause distress. Also, the idea of things that provide comfort can be really helpful for someone who has co-occurring ASD as well. And also mood, anxiety. I think someone else brought up like OCD earlier in the week, and absolutely OCD being part of the anxiety spectrum. Movement disorders can all be co-occurring. Yeah. And so I'm just looking here. And so I'm just noticing more comments about Jessica here about, yeah, definitely communicating with the school to find more information about background. All right, so I'm going to move into some of the cultural considerations for managing intellectual and developmental disability. And actually, some of this is just important in general, whether or not a young person has IDD. But always thinking that youth and families are impacted by the larger culture in which they live, and how culture views a behavioral health crisis and a developmental disability will greatly impact like the internal messages, external supports, and things that can either help or hinder treatment. So for some cultures and communities, just like the crisis itself can be really met in a certain way. Sometimes there can be associations around shame or concern or overwhelm, because maybe other things that people are definitely dealing with within a culture. But then also there's the developmental issue itself that can have a certain type of meaning. And so if we're thinking about intellectual and developmental disability, right, it's a disability. It's making it hard for people with this particular impairment to function in our culture. That's what a disability is. It's like when we have a particular impairment, it's like we're disabled because of the structures of the larger culture. That makes it hard for us to function. So then how does any particular culture understand the disability etiology, whether or not they seek help, treatment options, and the relationship with health professionals? And again, thinking also about children as opposed to adults, like they're just learning about the potential disability. The family itself is potentially learning about the disability. So they might not know, again, maybe I'm thinking if they're newcomers, especially new to our communities, about like what might be offered in schools, what might be offered in the larger healthcare system. And also I think about this a lot too. If there are issues around documentation, that can keep families really concerned about like whether or not they can even have access to services because of their documentation status and their fears that they have around deportation and such, real fears for families, right? Like, and so how do we help think about linking to services where we can comfort them about the services that can be provided for someone who doesn't have documentation. It's an important piece there as well. Also, in many cultures, like interdependence and individuals' role within a larger family and community is highly valued. A lot of people, come from cultures that are collectivistic, right? And so this idea of like autonomy is like is not seen as important. It's not valued in the same way as it is in like our dominant culture in this Western culture, and that can also affect how disability is perceived. Many times I've seen collectivistic cultures like this. There's any kind of disability, like the person is more cared for and supported in particular ways by the larger community. Many people also seek out traditional alternative medicines and spiritual healers, and that's an important thing to respect and also think about how to integrate into treatment planning or crisis planning. There's also aspects too about like spirituality that might also connect around the disability as well. So sometimes, families and communities have thoughts about, ancestors or spirits that might be, part of their understanding of their child's developmental disability. And sometimes that can be a source of, it can exacerbate the disability in some ways, but sometimes it can also mitigate it if the meaning that they ascribe to this connection, the spiritual connection, is depending on that meaning. So if the meaning is one of, this is support, this is specialness, that can be an important, helpful piece. And if it's, more concerned around evil, like that's something we, there can be a concern there in terms of the child's individual treatment. So we just have to understand it in the context and be able to have conversations with families, being culture, respectful of the culture, while also, being able again to reduce the crisis and to support the child. Always noticing the family's interaction style, like who's speaking first. And I always like, if I'm not sure, I defer to the elders, and always thinking about too, the eye contact piece. Some cultures have less eye contact than others. Again, thinking also in a crisis with the person who's in crisis, like intense eye contact, as I said earlier, can be problematic. Noticing common phrases, ways of speaking. Sometimes we do need to bring in translators, and that's really important for linguistic equity. And often our health departments in our various counties will have access to linguistic translator teams, or be able to know or link us to someone. And also, I'm really big into planning ahead. So if I know I'm going to be speaking, I'm working in a certain community where there's a certain culture that's represented, I want to plan ahead by getting to know that culture a bit. Some of that's through, book learning, but by going to people's like, social events, community events, becoming, familiar with who's out there is I find personally rewarding, but it's also really helpful for this crisis. If people, you have a sense of someone's culture and how they are respected. And then of course, humility and curiosity should always be our guiding approach. So I can have what I think is like some cultural competence, like some knowledge of these folks in my community and different communities. But then also, when I go and talk to a culture that I'm not a part of, just being like really humble about, I can't make an assumption. This is how you deal with things, right? Like I have assumption of this is how the larger community might approach something, but in your particular family, because of acculturation or assimilation, that can be a big difference. So a particular cultural community that we want to speak about here also, especially among young people, is the LGBTQI population, because of the level of crisis and risk and safety issues, really important. So suicide just in general is a second leading cause of death among young people ages 10 to 24. I believe, I think for college students, I don't know if I'm sure I got this right. It's like college students sometimes like it's like accidents, suicide, then homicide. For non-college students, it's like accidents, homicide, and suicide. So it's always up there, depending, for people from 10 to 24. And LGBTQ youth are four times as likely to attempt suicide than their peers. And this Trevor Project 2022 national survey really brought up some important information that we need to know. So first of all, we have almost 2 million young people who identify as LGBTQ seriously consider suicide each year in the US. At least one attempts suicide every 45 seconds. And the LGBTQ youth mental health survey that they did, they found that 45% of youth seriously consider attempting suicide in the past year, those who identify as LGBTQ, including more than half of transgender and non-binary youth. So such important data, because you are going to be speaking probably to LGBTQ youth in the community. And so knowing about that culture, knowing about the resources, the Trevor Project being a really important resource among others is really essential, right? And knowing the kinds of challenges that young LGBTQ youth are facing, just absolutely important. And I also think, like, I'm out here in the Bay Area, I'm actually sitting in San Francisco right now. And so I am surrounded by tons of resources. And I'm also surrounded by a community that generally has a lot of support for LGBTQI youth. Not that there aren't people who are who don't support. There are. I mean, there's always in our community people who, are very bigoted towards any kind of LGBTQ lifestyle. And so that's something that's really, important to know, but also knowing like where you're at in California, because in some places, not only there are less resources, but there's, more active like community, anti-queer, anti-LGBTQ like activism. So that has a huge impact on the whole community and especially on young people. To be unseen in that particular way is really dangerous. So our being present and being able to, link people to care, to have conversations, to be reflective, to be supportive, to let people know that they're valued is literally life-saving work for this community. So it's really important. And to really to normalize like the stress that they're under, as well as noticing their strengths, their value as young people, that this is important, that they're able to to talk to people, to have a community. And again, respecting pronouns is a critically important piece. I saw a meme the other day. It really, really reflects on this bullet. It said something to the extent of, I have to find it because I want to use it. Respecting pronouns is suicide intervention. It's suicide prevention. Respecting pronouns, understanding pronouns, like using pronouns is suicide prevention. Absolutely true, right? Because that means like I see you, I care about you, and I honor your identity. So importance of providing responsive resources to children and youth caregivers when appropriate. So we have to check with the young person first because we don't know if they're caregivers, if it's a safe environment. We don't know if it's a safe environment. So that when appropriate, being in bold is a really important piece. So here are some simple reflections here. So I think these are things that we were talking about certainly earlier, and we can also think about, so I'm talking about like cultural pieces as well, how some reflections might be also useful just in responding to, to someone's, cultural stress, right? And to, that feeling alone, maybe not feeling heard, or feeling like literally unsafe. Being able to say to a young person, like, it's completely understandable. It's be like an aspect of validation that, being picked on at school can make you feel very angry, like your head's going to explode, and that might be in the context of someone being LGBTQ or, any other, type of way they might feel different. I'm feeling that you're feeling sad that you were left out of games today. That could be an aspect of a reflection. You're hurt because no one ever seems to listen to you. Another example of a simple reflection. And all of these are just like so important, again, for psychological safety. So through all aspects of, even if someone has various levels of intellectual disability, different cultural backgrounds, this aspect of being present, being able to use reflective listening is like so important for someone's well-being. So one of the things we talk about again is we talk skill sets here, getting back to like the reflective listening and also thinking about like open-ended questioning being important. And to be important in terms of just like help me understand types of questions, helping to wonder or be curious with someone. We're going to get to assessment at some point, and we'll have a certain amount of assessment, and we refer someone to care. They're going to have even like kind of more assessment, but it's really important that when we ask questions that allow people to respond in ways that that they need to, that we get like enough information, but that we're not over inquiry. That we're not doing over inquiry, because anytime we ask a question, we're asking people to give us something. And the more like we ask them to give us, the more stress it puts on someone, especially a young person in crisis. We want to get just enough information that we can start to reflect and join and understand their dilemma, but not go immediately into like this over assessing, because that also increases more crisis, potentially increases more stress, increases more agitation. Knowing that we'll get there. But the most important thing we do is we're just slowing it down, understanding their dilemma, and just helping them feel kind of safe and heard. So we're on to some of our last pieces here, then we'll take some questions. We're doing our time. Okay, we're doing okay. Is Not surprisingly, youth who are in the child welfare system, so I call it CWS here, um, have histories of trauma that make them more vulnerable in entering crisis. And we're trying to figure out ways of children in the system, like kids in the system, so to speak. How can they access resources that they'll help them learn how to self-regulate and gain support in order to recover from current crisis? What's challenging here is that often kids, in the child welfare system, clearly, they're there potentially because they have a history of trauma. Often these youth, even if they know or they have a sense like this might be for the best, not all the youth feel that way. So they might already just be in crisis just by being in the system. And so we're trying to always kind of figure out like how to help stabilize, provide hope, provide resources, for them to see like the hope and that someday they're not going to be in the system. Someday, they may have this opportunity, they will have an opportunity to live in a much different environment, right? Whether that's back with their family, whether that's in a stable adoptive home, whether that's as an adult. And we don't want to necessarily say, oh, everything's going to be okay, this is just temporary, because at the time, right, this is a really distressing situation for them, often being in the system. It's already lays like a certain level of stress often, and then something happens at school, and then something happens that invalidates them, and that really, again, increases the vulnerability for crisis. So we are certainly going to try to connect with the caregivers on the scene and see what kinds of resources are available, again, what kinds of things activated the crisis, and that in addition to a care coordinator that often a child in the child welfare system will have, because usually there's someone kind of responsible for overall care coordination. There's often other important professionals who can really be connected with in a way that can help us support this young person. Often there are behavioral health therapists that are assigned, or there's a social worker. Often they're the care coordinator, but there could be others involved. There can be resource specialists involved, including behavioral health coaches or behavior coaches, because many times, because of histories of trauma, youth are connected to behavioral coaches, pediatricians and a psychiatrist. Many times kids are being considered for meds or on medications. Occupational therapists, again, early trauma often shows up somatically. Occupational therapists are often on board to help work through that trauma, and often are fantastic. I love OTs because they're great with like a lot of self-regulation, because they really understand how to work with young people and adults somatically to find these paths for self-regulation that are physical. Attorneys, I've had attorneys be great. Clearly they're advocates. I mean, they are the child's advocate in many ways. But I've had a lot of attorneys who've worked with kids in the system who are like really compassionate and care a lot about the youth, and can be helpful if there's a situation that's occurred that's creating crisis, to help talk them down, to help them. I'm on your side. Court-appointed special advocates, CASAs, are often really helpful. There's probably other people too. These are just some of the folks I've used a lot in the past. And it's not uncommon for one or more of these folks to be available during a crisis to kind of help with support, and sometimes just even with their presence. So there's crisis safety planning and follow-up strategies for youth and families in crisis. So again, this idea of like, we're going to be checking back, there's a mobile response team in 72 hours to make sure that people have what they need for continued resolution of the crisis. And for updates, ongoing referrals and supports. And again, a lot of youth that we've been talking about, have some aspect of resource, if anything, like potentially from schools, again, all the way up to the child welfare system, where we may have like a lot of resources. But we have attached here in this training as well, many resources that could be considered if people aren't already linked. And we're thinking about short-term and long-term prevention strategies. I included here because I really like this, and it's used a lot in suicide prevention intervention, but I think it's helpful for so much crisis, is a Stanley Brown safety plan. And there's a lot of research around Stanley Brown. So it's been evaluated a lot. And if you look at it, you can click on it, you'll see that it has people looking at what are their internal and external resources, some aspect of like warning signs when I'm struggling. We think about creating safe environments. So if someone like has a plan to harm themselves or others, we do, think very, make sure that on that plan that we are deactivating any plans to harm self or others. There's also, a collection of like, what are our community resources so that we can put that all together. SAMHSA also has a digital safety plan as well. So you can check these out. And it's that one's modified Stanley Brown. And you make sure you have them. Again, you probably already do, but you have like your digital versions, whatever versions you need available to be able to work with families. I know you probably have to think of a number of different ways of doing your plans. I'm sure probably everything's digitized, but we also sometimes have situations, again, your teams might be set up slightly different around this, but I know having grown up in and worked in a rural environment, sometimes you have everything digitalized, but you end up, way out in the back without any internet in order to use that. So I often encourage like paper copies of things as well, because you never know. And so again, some of the things that we're thinking about in this crisis safety planning, and this comes up in the Stanley Brown and other areas as well, other types of plans, is what are some strategies, and what did we actually do? What did the person actually try? Were they willing to try? And what seems to be effective or ineffective? We're going to toss off the things that are ineffective and really start to focus and reinforce on the effective behaviors. We're trying to not just stabilize this crisis, but help prevent the next one. Okay, so that's why this linkage is so important, and to help support families in linking to resources, because people can get a list of stuff, but if we can help, if we have any capacity to help with a phone call, to help with a name, to help do more of a warm handoff to where someone's actually being connected through our efforts to a resource, that really does help with actual follow through. And we want to encourage rapid appointments. So if there's a way of, again, being able to kind of smooth that path to make sure that folks are getting connected as soon as possible. I know there's a medical requirement that people are linked as soon as possible, and that providers get back to folks. But again, whatever we can do to kind of make sure that we're using the resources that can be linked to them most quickly, that's of course preferable. And then it's always helpful to be able to, continue to have conversations with the emergency department staff to follow up to make sure that people have received care once linked to the emergency department. I am also a big believer too, and you very likely are doing this, but to develop relationships with folks in your emergency department. Because we want to be able to have conversations and with them before all this crisis occurs, or develop relationships, just like friendly, warm relationships of being collegial, because we rely on them a lot and they rely on us, for information. So we want that to go smoothly. We want to be able to have this situation where there's ways that we support each other, ways that we partner, providing information, making sure if we know things that emergency department needs, that we've filled things out really well for them so they don't have to ask a lot of questions, because we want to smooth the path of all of this communication and being in partnership, being friendly, knowing each other, and on some, not personal, like, we go over to their house for dinner kind of thing, but just like developing kind of a friendly relationship that you would have is really important. It may seem obvious, or it may seem like, we're at work or whatever, but there is an importance around how we support each other when we're out doing this kind of work, because it's hard, and we do rely on each other for for completing tasks, put it that way. And there's a lot of things we can do too to support parents. There's a lot of great parenting education programs. I'm sure you all know more than I can even think of. I was thinking, of course, parent-child interaction training. There's so much parent-child interaction therapy. There's a trauma-focused CBT that involves parents as well. There's all kinds of things, probably aspects of functional family therapy, lots of good stuff that can really help folks if we can find linkages in our community. And so make sure you know what those places are in terms of parenting education, family therapy. What does behavioral health provide? And increasingly, we have some really good online resources for some of this as well. So we want to be able to make sure that the behavioral health providers are involved and know like what's occurred, and that they're following up. What are some of our outreach with regional centers, and FERS? I'm sorry, I'm just completely blanking on FERS. I know what that is, but I'm just completely blanking on the acronym. So we can add that in the chat box. Schools and other delivery systems. if there's other things that aren't in place, like a case manager, maybe like a behavior tech, other resources that we think could be really helpful, we have a lot of state and local resources for that as well. Another really important person or people is like medical providers. A lot of youth that we see in crisis have connections with medical teams, including psychiatrists. They want to be on board because there's things they need to know in terms of their interventions and their treatment. And if someone isn't receiving treatment, either behavioral health or psychiatric health, think about your mental health access line in your counties. Those are the folks you can call, and they can like start to help with the referral process. Also, warm lines are great. I love warm lines. I help consult with the California Warm Line, which is fantastic resource. They do incredible work. I mean, these are folks who are peer providers, very well trained, who take calls all day long from strangers and create safety and warmth and care in our community for free. They have phone lines and text lines, and the California Warm Line isn't necessarily like for suicidal. They have people who call who are suicidal, and they make those links. But it's just for loneliness, for stress, for crisis. There's also the crisis text line, and there's also the 988 lines. The Family Urgent Response System. That's what the FURS is. Sorry, I completely forgot. I knew how to do with families, but I couldn't remember what the FURS stood for. And regional centers, and both of these centers are kind of they are many ways like kind of fully resourced centers where they can start to help link to different types of care. In this case, for family, regional centers for folks with IDD, for individuals and support family caregivers for people with IDD. And I have here for discussion. I know we're probably getting into some questions soon. But if there's other things, are there other things too? I'm having effective communication strategies that maybe I haven't talked about. But also, are there some resources that, I just listed a ton of resources. You're going to get a lot in your chat box. But are there some things that are your go-to that you really use a lot that maybe I haven't mentioned, and you want to make sure that people know? While you're doing that, I'm going to kind of look here. Would you consider respecting pronouns be a form of gender affirming care? Absolutely. Family, yes. Okay, some of you are helping me out here with the Family Urgent Response System. Thank you, and you're adding information there. Great. Thank you for your help around the FURS. Okay. There's a question here I might save for the end here too about with eloping behaviors. Yeah, that's something I might have y'all kind of help me out with that one. For someone who's taken off from the scene. So I mean, I think that still is an aspect of crisis, and when someone's with us, we can again think about like what's the purpose of the same thing, like what's the function of that behavior? What's someone trying to do? Are they trying to get away from something, or are they trying to go to something? That's like kind of an important piece to solve for someone, and then what kind of coping can potentially occur around that. So I'll get back to that in a minute. Just kind of finish up with some of these other pieces. Okay, so some of this already come up already. So with the California minor consent laws, this is an important thing to know. A minor who is 12 years of age or older may consent to outpatient mental health treatment, counseling services if, in the opinion of the attending professional person, which include us, the minor is mature enough to participate intelligently in the mental health treatment or counseling services. And if the services are being provided by licensed interns or trainees, there may be an obligation to consult with supervisors. Okay, that makes perfect sense. And so there's a lot of different, types of situations in which there's minor consent laws, and we actually have these tables attached, which you can kind of look through. For counseling services, for psychotropic medications. Again, that's a little different, right? Because you wouldn't be prescribing anyway, right? But you can see the consent law here, only with parent guardian consent. Except a guardian cannot consent to experimental medication for a minor. Inpatient treatment, convulsive therapy, these are things you're probably not getting involved in. But for the, drug and alcohol treatment, a minor, 12 years of age, can consent. Drug counseling. See if there's another one here. General medical care for emancipated minors, they can consent. So clearly the things that are more like involved in invasive, like convulsive therapy, which is not things that you're gonna be working with anyway on your teams, but you know, some of this may feel like it's a little more in the common sense kind of category, but with inpatient psychiatric, you definitely need to have parents involved typically. And here's the thing, you know, with outpatient mental health and substance use treatment, again, yes, like a young person can consent, and that could be really important for case of safety. I mean, have had young people where their safety at home was a concern. They did not feel physically safe, especially in situations where the child may have identified as LGBTQ and their family was not supportive, like really important situations that they're able to, you know, consent for counseling. But there's, you know, many situations where, again, as you've noticed in this presentation, where we want to try to involve caregivers. So if I can involve caregivers and you know, and you know, makes sense to, I really want them to be as involved as much as possible. So there may be a situation that even if someone consents, they're a young person and they consent on their own, or having a conversation, you know, I will, you know, try to think of, you know, as I assess in my mind, I'm talking with this person, like, is it safe? It might be possible that really would be a good thing to involve the parent. Maybe that's something that they would agree to. I would never force that, it would always be an aspect of choice. But to the extent that, you know, it makes sense, I might inquire about that. So these are important things, of course, to be aware of as well. And you can read some of these in your more time if you want to actually go through and read, and you should go through and read these. In fact, I'd encourage you to print this out and have this available. So we are getting close to the end here and are at the summary time. So these are some things that we went over, and there's a lot going through that we want to talk about here. That trauma-informed crisis resolution and de-escalation strategies prioritize empowerment and choice, and that careful active listening, collaborative care is a really important piece. We're thinking about crisis behavior as a symptom instead of a cause, and that trauma-informed management is important in terms of the behavioral health crisis. So cultural pieces are really important, that everyone, of course, is a part of a culture. And you know, we often have people who are part of, you know, minoritized cultures in the larger community. And all of that can be important in terms of, you know, the culture's standing and safety in the community, as well as, you know, their own acculturation and assimilation. But we really want to be, you know, thinking about culturally, how did they come to understand and work with trauma and crisis when it comes up. And also, of course, we spent a lot of time talking about IDD and developmental issues as well, and really thinking very carefully about how IDD might present and how we might adapt how we're communicating with the young person and the family. Also being thoughtful about the child welfare system, because of the nature of, you know, why young people are brought to the child welfare system. They're often, you know, in situations of high stress and trauma to begin with, that may make them more vulnerable to crisis. And also being involved in the child welfare system may have them already set up with a number of supports that we want to be aware of, because they can be very useful during crisis management. And also here, we want to make sure, of course, to be thinking about our crisis plans and doing follow-up. And safety plan is an important piece, but also linkage to care, knowing the different types of resources in the community, what the youth is already connected to, what they might qualify for, you know, what we might not be thinking about. Maybe we can collaborate with others to brainstorm if we think we don't have a resource. There's often something out there, and thinking of our own skill set to include, you know, linkage and warm handoff. So folks are more likely to engage in a service if they have us kind of helping to smooth the path in terms of communication with that resource. Okay, so we have some time here, which is great. You can have like an extra 4 minutes, I think, to ask and answer questions.
Let's see. We talked about Benjamin's chat.
Yeah, Benjamin, I like Benjamin's chat about the 50 minutes of silence until I asked about the Star Wars picture he was drawing. Like what a great like intervention. It's like the noticing, right? The observing like what's important for that person as a gateway. It's a great story. Thank you.
Yeah. So Carrie Wood is asking about eloping behaviors and how, as a mobile crisis team, they can manage, especially with a hands-off approach and policy. That's a great question. Eloping happens, especially it happens more often with youth. I've been in situations where I've been out on a call and, kiddo just took off, and we did have to engage officers just for safety. The kid was running in the street, there was traffic. And so we unfortunately did have to call out the officers because we couldn't go hands-on, and the caregivers were not in a position to initiate safety at that point. But go ahead and whatever you have to add, Dr.
Yeah, I think I started to answer that one and then like, let me finish this and I'll get back to it. So thank you for finishing that. And but that is the important piece there is we can deal with eloping behaviors like when we're sitting with someone and they're able to talk about them, and maybe it's something they want to do or they've done in the past, thinking about, and again, trying to understand again the function of that. I remember learning many years ago, having someone teach me when I was working with youth who were eloping, and back in the day, we referred to it as like runaway. That was kind of what we talked about, runaway kind of prevention, and that was always, I think, a very important piece of like, are they running from something? Like, are they feeling unsafe and scared? That's one thing. Or are they running to something else? So sometimes we also have youth who are like they're running to like a partner or someone they want to be someone that who's potentially an intimate partner or like a friend, like friend's house they like better or what have you, and trying to think like what are the motivations behind that, and being able to potentially work with the young person around, okay, we have lots of different like tools and resources here. Leaving your home may or may not be an option, but being able to have that conversation, and I think that is really important, again, to be heard and have some sense of like, let's try to understand the function of that behavior. That does tend to slow it down. And you're right, like if they just get up and run. I also think that getting up and run, again, it's like the mutism. It's like, I need to have control over this situation, and this is one way I'm going to do it. So I'm going to split, which works. But okay. But you're right. Like as we can't be hands-on. So that would be something where probably one of the examples of it would have to engage law enforcement for safety, because, depending on the situation, and in most situations, I suppose if we knew, like for example, the youth was getting up and running across the street to the aunt's house, that'd be one thing. But if they just, they get up and they're, we have no idea where they are, and we're really concerned about their safety. Yeah, they would want to be able to have somebody assess that. I'm looking at okay, I'm looking at the other comments here. So that's an interesting thing too, where like everybody's maybe having a hands-off approach, right? Where law enforcement's hand off and they expect you to do it, and it's like, wait, but we can't. Yeah, this is a really difficult situation, and it might be one where it does kind of go back to the local level, because ultimately, honestly, like law enforcement having a hands-off approach is in fact a preferable situation. Clearly, I mean, no one wants to be putting hands on youth, to be sure, and yet, I mean, that is a legitimate question. If someone is, again, it's about the idea of like immediate risk and harm. Like, how do we assess that when it's out of our hands and they're running, and then how is that responded to? So this might be something where I have folks like really defer back to your teams about what kinds of things can you negotiate or think about with your local law enforcement about how that would be handled. Hope that was like a reasonably helpful thing. I know that's a tough one. And nonverbal youth, I'm looking at Carrie's comment too. Nonverbal youth are like really common. And again, I think it has a lot to do with control, patience, persistence, inviting into, lots of different other types of communication tools. And here's another thing to think about around this is that any one of your individual interventions with like a young person might feel like, oh, I'm not sure, that feels like it went over like a lead balloon, right? Like they wouldn't talk to me, maybe they took off or what have you. But if you're in a situation where you're sitting with folks and you are, really engaged in a way that is compassionate and sincere, and it's really showing their best interest, even I think with like the most like traumatized, angry, grieving young person, like that's meaningful. You're starting to build goodwill. You're starting to build some sense of maybe this isn't always the worst thing when someone shows up, so to speak. And so we're not re-traumatizing. Most importantly, like we're not re-traumatizing, which doesn't mean that it's like, there aren't that we can just, okay, we never have to be directive. Again, getting back to the place, like if we have imminent risk, like yes, obviously there's times when someone may have to it may not be you, but maybe law enforcement to be more directive. But even in times when we're feeling frustrated, I think that intention, the way we show up is still building a bridge. I guess that's what I'm saying. They're still building a bridge. Okay, I'm trying to see if I got everything here. Oh, okay. Look again at the chats. Okay. Anything else? I think. Oops. Make sure if I got everything here. One of our issue our youth crisis team runs into is a matter of needing parental consent or not, and when is the line drawn in terms of justifying adequate risk to intervene without consent. And I think the issue is a good issue to have, actually. I know it's not a satisfying answer, but it's one thing to have any kind of law or like here's a law or case, some aspect of case law or regulation, what have you, and we look at it and it's like, okay, great, glad to have that guidance. But then there's like real world application. Then there's, and just to be really honest, like this is the bane of many law and ethics kind of providers struggle. People who teach this stuff to practitioners, it's often a case where we can't have like case by case basis, right? We can't have these situations where like it's not entirely clear cut, and many times it's less clear cut than we'd like it to be. But what's important is that you're having conversations with your team, and you're really starting to think it out. So whether you end up like as a team, like seeing someone with or without consent, document carefully how you've consulted about that. If you've had legal consult as well, certainly obtain that, document that for some. Oops, I'm sure someone's talking to me. Okay, and it could be even county council if you have that kind of access, because what you're showing is you've done due diligence. You've done due diligence to like you've really thought it through, and that given what to be the regulations, given what you've known to be kind of best practice by incorporating a number of different ideas and supervisors and such, that you've done your best to make the right choice. It's what's concerning is when people are like, maybe it's a real quick decision, or someone's like, well, why did this person like not have consent? And we're like, well, I don't know. Or I just did it. Like that's problematic. But when there's like this sense of like, it doesn't mean you have to struggle with it all day and night, because clearly you can't. You're going to have to make relatively quick choices because you are a mobile response, but that you did your due diligence to really think this through with the time that you had, the best of your ability. That's often shows that was the best possible choice you could have made. So I hope that helps some. But consult is the best thing that we could possibly do, and having like pathways to consultation is really helpful, whether it's your direct supervisor or a team. If you don't feel like you have a lot of that, how can that be further developed? Right, Roxanne, that's a really great story. So Roxanne's giving us a really great example of like the importance of listening, right? And that sometimes we have all this complexity. It's always about, I don't want to oversimplify, but a lot of times with like a lot of complexity, it's the solution is just kind of being present and just kind of hearing and witnessing, and even just like a little bit of relief through a certain conversation, or a certain reframing, or a certain offering of maybe a menu of options of things they could choose from, can do so much to de-escalate. Yeah, I love that. Thank you for that.
I see Carrie's response in regard to responding to schools.
Yeah.
where they may have licensed staff, they may have unlicensed staff who are working with students to determine their risk level, and their ultimate ability to stay safe. And they may request the mobile crisis team to come out to support the de-escalation, and they may be saying this student needs to be placed on a hold. They meet criteria, but essentially, unless you are a designated individual, you do not have the authority to determine if someone meets criteria for a hold. And so it is the due diligence of the mobile crisis responder or the team, whoever's going out, to make sure to, yes, coordinate with that collateral, get as much information as you can from that person, and then working with the students to get clarity. Ask questions if you need to, or the approach that Dr. Dempsey, questions aren't always necessary, right? We can sit in conversation and dialogue to get the information we need. But at the end of the day, a designated individual needs to make that determination.
Yeah, and I think so happens too at schools too, especially because people are busier. There's not, like, oh, I want a second opinion. So it's like, here, I'll just call the mobile team and they can do that for me, kind of thing. And then you're right, like it's like these young people get like totally over queried, and then they don't like it. Like they're over it. Like, I don't want all these people asking me all these questions. So the thing is, if you sit with someone, probably within a reasonable amount of time, I think be able to have some sense of like, this person's escalating more, but or or they have a means. I'm not really sure. Like, maybe I do need to do this, but many, many, many times it's like you're sitting with them, and especially they might be a little annoyed at this point. So they've been asked, but they've de-escalated maybe, or the being there and again holding the space and just being able to reflect upon this dilemma. I think maybe a great use of your time there is, if they're not imminent, right? They're not, okay, I really got to get somebody in here, is really focusing on that safety plan and linkage piece. Safety plan linkage. So it's like, if they're, I'm over like having somebody keep asking me questions. If I kind of shift the response to, once we know, like, again, they're not even going to harm themselves. Like, what kind of resource do you have? Have you heard of this resource? Can I connect you to a resource? Like, using time for that, like a warm handoff, like that could be a really good use of time, because again, we're giving the person something. We're not taking from them by asking like more questions. It's like, I'm going to give you something that might be really helpful right now. Would you care for that? Would that be helpful for you? From what I understand, the schools have when legal rights holder, even if the child doesn't want them. Yeah, that's probably true for sure. Okay, right. So yeah, so that's an interesting piece that many of you are getting involved in, that like there's someone maybe wanting to cover themselves, and like to say, kind of covering their base, like, legally I want to be protected, so come check this out. But the reality is that maybe the person isn't really like imminently at risk necessarily, or they're pretty stable, like, but you're assessing when you get in there, like they just need to hear somebody, someone to hear them, someone to be present for them. And again, I think the linkage and the resourcing piece can be really powerful.
Yeah, definitely. And I think that is an often thing that happens, is you often get a call for mobile crisis services, and it's automatic that the reporting party or whoever's calling is saying they need to be taken to a hospital, they're not stable, and no intervention has been done yet. And so that's hard, and it is our job to explain the process, especially under this benefit, right? This benefit is not aimed to go out and determine criteria for a hold. This benefit is really about brief intervention in the community to provide someone with relief from their crisis. Now, like Dr. Dempsey said earlier in the presentation, that we're not going to be able, it's not going to happen for everyone, right? Some people are still going to have to go to the hospital. Unfortunately, they're going to need that. They're going to have a higher level of need. And they won't be able to maintain safety. So that still will be a challenge at times. But in terms of crisis services and how it works with minor consent laws, is, if a student is at school, and the school team, as the referring party, has asked for the mobile crisis team to come out, they do have a legal right, to inform the parents of what's happening. But there could be situations where there's an immediate safety issue if the parent were to be informed, and that's a determination we have to make. right? That could involve the child welfare system. It could involve a mandated report. And it's just so complex. Like each situation can be very complex. And like Dr. Dempsey said, we have to just really take into account the level of due diligence we have to put in when we're working with anyone. And as a previous crisis responder, it's a complex world, right? It's not as black and white as we would like it to be sometimes when it comes to how do I do this or what should I do here? There's a lot of gray. If you have any questions or any wonders, you can always email us at mobilecrisisinfo@carsrp-rp.org, and we'll put all of this in the chat. It was great to have you all here.